This recording will go over constipation, encopresis, and hypertrophic pyloric stenosis. So constipation, I'm sure you're familiar with. Your book defines it as a delay or difficulty in defecation that has been present for 2 or more weeks. A major concern with constipation is the development of encopresis or fecal incontinence. Encopresis is repeated involuntary defecation in a child older than 4 years who has a normal colon and rectal anatomy. With encopresis, children often report that soiling occurs without warning. Parents find the situation frustrating, and soiling often becomes a major issue between the parent and child. Often, encopresis causes children to feel ashamed or embarrassed, and they may avoid situations in which embarrassment might be heightened, such as spending the night with a friend or even going to school. If the condition persists over a long period, it usually affects the child's self-esteem and may impair social relations. Parents can experience a range of emotions, including guilt, shame, disgust, or anger, and they may project these feelings onto the child. When stool passes into the rectum, distension of the walls stimulates mass peristaltic movements in the bowel. This process is called the defecation reflex. If defecation is not desired, the external sphincter contracts and voluntary retention of stool occurs. As the stool remains in the rectum relaxes and the defecation reflex wanes. Water reabsorption from the colon continues, resulting in hard, dry stool that is difficult to pass. The eventual passage of that stool can cause pain or anal fissures. If retention of stool continues, more fissures develop or become worse, so that eventually even soft stool produces pain. A cycle of pain develops in which the stool is retained to avoid pain, but the retention leads to even more difficult defecation. Over time, the rectum becomes enlarged. An enlarged rectum can result in failure to control the external sphincter, which in turn results in encopresis. Constipation can have many causes, such as changes in diet, dehydration, lack of exercises, emotional stress, certain drugs, pain from anal fissures, or excessive milk intake. If the child has no neurologic or anatomic disorders, encopresis is usually the result of recurrent fecal impaction and an enlarged rectum caused by chronic constipation. The principal symptoms of constipation are the absence of stool, abdominal pain and cramping without distension, and palpable, movable fecal masses with large amounts of stool and an enlarged rectum. The child may also experience diarrhea overflow, normal or decreased bowel sounds, malaise, anorexia, headache, nausea, vomiting, and anal fissures. Children with encopresis have evidence of soiled clothing and fecal odor without apparent awareness. Anal irritation leads to scratching or rubbing of the anal area. Social withdrawal and avoidance of extended contact with others are common. Urinary incontinence and urinary tract infections may also be present. The best form of treatment is preventing the development of a chronic problem through appropriate diet, exercise, and regular toilet habits. Education about normal bowel function can prevent a psychogenic component from compounding the problem. The focus of management is to remove any impaction, retrain the rectum so the child is aware of when it's full, and help the child overcome the pain retention cycle. The first phase of treatment is disimpaction. Enemas, stool softeners, and laxatives may be used. The second phase is education and demystification. Extensive discussion with child and family about causes of constipation and discussions about feelings, social consequences, and embarrassment occur. The child and family need to be assessed for readiness to change. In terms of maintenance, the child may take mineral oil, lactulose, or Miralax to help encourage soft, easy-to-pass stools. Dietary changes could include limiting milk intake, increasing water and fiber intake, and increasing residue. In order to help change the retention habit, the child will be encouraged to sit on the commode for 5 to 10 minutes, approximately 20 to 30 minutes after a meal. Behavioral charts with positive rewards can be used. The parent should avoid negative reinforcement. Use biofeedback, a potentially useful tool to reteach the feeling of rectal fullness, and also increase physical exercises, relaxation activities, and the use of stress reduction approaches to decrease anxiety. The goal is for the child to pass 2 or 3 soft stools per day without pain within the first month following treatment. Medications are withdrawn slowly over a 3 to 6 month period after the fear of pain is gone or significantly diminished. For infant constipation, rectal stimulation, such as rectal thermometers or glycerin suppositories, are discouraged. Barley cereal can be substituted for rice cereal. Ingestions of fructose, such as prune juice or lactulose, can also help. High fiber fruits and vegetables will also decrease constipation in infants. Please review the purple nursing care box for the child with constipation or encoparesis on your own. Now we're going to talk about hypertrophic pyloric stenosis. Pyloric stenosis results when the circular area of muscle surrounding the pylorus hypertrophies and obstructs gastric emptying. So if you look at this diagram here, so the pyloric sphincter is located between the stomach and the duodenum. And you can see with pyloric stenosis how hypertrophied that muscle mass is, making it difficult for substances to move from the stomach into the duodenum. With hypertrophic pyloric stenosis, pyloric spasms cause milk curdles to be propelled against a narrow pyloric channel with subsequent irritation of its sensitive mucosal lining. Edema of the pyloric mucosa results. This edema further reduces the size of the pyloric canal and creates resistance to the flow of milk. To promote gastric emptying and compensate for this resistance, the pylorus contracts with more force and gradually enlarges. The enlarged pyloric muscle slowly begins to constrict the pyloric channel, and when the mucosal edema subsides, the resistance to flow still remains. A vicious cycle develops and progresses to a high-level obstruction of the pyloric canal. Progressive projectile non-bilious vomiting, usually starting after 3 weeks of age in a previously healthy infant, is a major manifestation of pyloric stenosis. A movable, palpable, firm, olive-shaped mass is felt in the right upper quadrant. This mass is most easily palpated when the stomach is empty and the infant is relaxed. Deep gastric peristaltic waves from left upper quadrant to the right upper quadrant may be visible immediately before vomiting. The child will be irritable and hungry a short time after being fed. If the condition progresses, the infant may become dehydrated and experience metabolic alkalosis. The diagnosis is made based on a history of vomiting, visible peristaltic waves, and a palpable pyloric mass. When the mass cannot be palpated, ultrasound can be used to confirm diagnosis. X-ray and barium swallow can also show signs of problems with the pylorus. Because pyloric stenosis is usually diagnosed early, few infants are seen in advanced stages of dehydration, malnutrition, or alkalosis. A pyloromyotomy, an incision of the pyloric muscle to release the obstruction, is the definitive treatment. It is not considered an emergency procedure, but is usually performed without delay in well-hydrated infants. Please review the purple nursing care box for the child with hypertrophic pyloric stenosis on your own. When gathering information about infant vomiting, be sure to include the following questions. Can you wipe the vomitus off the child with a rag? Did the vomiting require a change of clothing? How big of a circle did it make? Does it happen with every feeding? Did it look like what was eaten, or was it curdled? What color was it? Did it appear to be projected away from the child? These questions help give us good information about the quantity of emesis, the force with which it is ejected from the child, whether it's just sort of spit up that a parent might be overly concerned about, or if it is indeed vomit and a major or more severe problem may be the cause of that projectile vomiting with every feeding.